Hello, and welcome to the Dr. Money Matters podcast, the show where we discuss important financial topics that were never covered in med school. I'm your host, Dr. Tarang Patel. Are you tired of the constant attacks on physicians as if we're the problem with healthcare? It seems like there's a never-ending barrage of negative news stories about why physicians are the source of healthcare problems and costs. It seems like there is a coordinated effort now to paint us negatively, while the other participants in healthcare, such as insurance companies, corporate entities, and large healthcare systems, pharma, seem to get off a little easier. It's because they have well-funded lobbies and third parties that are supporting them through various incentives. Physicians are spread out. Most of us are not members of the AMA. And we know that the AMA doesn't necessarily represent all physicians equally anyway. So what can we do other than take these little attacks, each one from the New York Times, Washington Post, whatever media outlet, whatever side of the aisle you're on? We take them, they grate a little bit upon us, and then we move on. But after this constant barrage of attacks, you start feeling a little bit more burnt out, a little bit more upset, and you enjoy your job a little bit less. Well, this weekend, and actually last week, an article from Dr. Karen Sibert, an anesthesiologist in California, went viral amongst physicians, and then ultimately went viral amongst other healthcare professionals and non-physicians as well, talking about her response to a couple of articles in the Washington Post, one of which called Physicians Muggers, specifically a surgeon a mugger, and another talking about a Nobel Prize-winning economist who said physicians were rent seekers. So she wrote a tremendously well-written article and a pointed article as a response to it that I think most of us who are physicians and healthcare professionals could really take to heart. And she did it in such a well-written way. You're going to, learn that she's actually an English major, but she's been a practicing anesthesiologist for a while, and she's seen some stuff in her career. And despite it, she maintains a positive attitude and says that she wouldn't trade, being a physician for any other career. And sometimes it's difficult for all of us to feel that way, particularly when external forces are attacking us. I mean, we already have a difficult enough job as it is. So anyway, I apologize if the audio quality wasn't as great. I'm trying a new recording system. I'm not sure it's as good, but I wanted to get Dr. Sibert on as quick as possible. And so I'm not really going to be doing much editing here. I think she spoke, what she said was articulated so well, there's really not much for me to edit. But if there's some issues with the sound quality, I apologize. But I wanted to get this out there. Okay, welcome back to another episode of the Dr. Money Matters podcast. My guest today is Dr. Karen Sibert, an anesthesiologist from UCLA, who wrote an article last week as a response to some of the negative articles that have been coming out in the media recently, including the Washington Post article that described a surgeon as a mugger, a Nobel Prize-winning economist attacking physicians by calling us rent seekers, and just numerous other articles that have been coming out over the last few years, but it seems like they've been coming out with more frequency recently, basically undermining what physicians do and just insulting us in our profession. And so Dr. Sibert's article from her website, A Pen Point, and then subsequently was shared on Kevin MD, gained amazing traction. Last I saw, there's like 110,000 shares on Kevin MD, and I think it brought down her website over the weekend, just because it was so much traffic, because I'm assuming that so many physicians agreed with it. I know that's the case because most of the comments on social media, Twitter, Facebook, were basically saying this is so spot on, that she gave voice and words to what many physicians have felt, over the last few years, and it seems like it's coming to a head. So, Dr. Sibert, thank you for agreeing to come on this podcast, and I wanted to get your voice to the words that you wrote. So, thank you so much.
Oh, it's my pleasure to be here. Thank you.
So, a little bit about yourself before we get into the topic of our discussion. So, you're an anesthesiologist at UCLA.
That's correct, in the Department of Anesthesiology and Perioperative Medicine. And I'm also a past president of the California Society of Anesthesiologists. As far as my interest in writing, as you might be able to tell, I was an English major originally, and my first job actually after college was as a reporter for the Wall Street Journal. So I've been writing for a long time, and as my husband would tell you, he says, Karen thinks everyone is entitled to her opinion.
Well, in this case, I would say that like 99% of physicians would agree with what you said, and really without changing any of the words. So I want to say, the first line of the article was right off the bat, just was brilliant, caught our attention. You basically said, and I'm going to quote this: "If physicians are muggers and co-conspirators in taking money away from the rest of us, then journalists and economists are pontificating parasites who produce no goods or services of any real value." Wow, that is powerful stuff.
They really, really got on my last nerve, I guess you could say.
Yeah,
we all work very hard, and all of us have worked long years to become physicians, and we really dedicate our lives to our patients, and then to have that sort of lack of respect and ingratitude and frank rudeness, it really got under my skin. I think that as physicians, we're always very loath to toot our own horns. It used to be 50 years ago, physicians didn't even advertise. But now, today, if you don't get on social media and tell people what you've done, nobody's going to know. And in this case, I wasn't writing about myself. I was really coming to the defense of my whole profession and of the residents and the interns and everybody. And it really, I guess my mama lion instincts were really coming out.
Absolutely. I mean, you're absolutely right that, we didn't have to do this before. We were always, and we still are, ranked generally very high on those most admired, trusted professions list. But it does seem like there is more license to attack physicians now. And so some of it, yes, we've heard it for years, but some of it just seems very pointed. And recently, like the articles, about the woman on the Washington Post article who talked about the surgeon who basically, according to the article, said that he needed $15,000 or he wouldn't do the surgery. And we know that, yes, of course, occasionally things like this will happen. But most of the issues with healthcare costs are not really directly physician related, and so yet that seems to be, of course, what the media seems to focus on. And so it was really good to see someone, one of our own, standing up for us.
Well, thank you. First of all, I'd like to say that as far as the Washington Post article, I do have a lot of sympathy for the patient who gets presented with a surprise bill from a physician who isn't in her network. Right. That has to be an awful experience. The out-of-network issue is very complicated. A huge part of the problem right now is that insurance companies do not want to negotiate fair contracts with physicians. They just don't. And some insurance companies are actually maneuvering to keep physicians out of network because they feel as though they can pay less overall if they don't have a contract in the first place. They really don't seem to care if the patient gets stuck in the middle of this. Now, I feel I would love to hear the surgeon's side of that story. I feel as though
Absolutely.
it's likely that he never expected to be paid that entire 15,000. Really, medical charges are kind of like prices in a Middle Eastern bazaar. Really,
Right.
nobody expects to pay or receive the full price. But the patient doesn't necessarily know that. I'm sure it was upsetting.
Right. Right.
But I can tell you, I've had the experience of being mugged. I mean, not injured, luckily, but I had a robber suddenly come up behind me as I was putting my 4-year-old daughter into her car seat and say, "Shut up and give me your wallet." And that is a far different experience from getting a bill.
Absolutely, absolutely, and we all. I'm sorry. Yeah, I was going to say we all sympathize with the patient because we know they're in no position, in certain situations to negotiate. So we understand that, and it's easy to go after the physician because it seems like such an outliers case. But you're absolutely right. There was no at least quote back from the physician. So it's a unilateral, presentation. And then secondarily, where was the second order thinking about why would a physician do this? And where is, we know now as physicians, I actually did a podcast with Dr. Amy Cho, an emergency medicine physician, about balance billing and the issues. And she exactly described what you're talking about. Is that the insurance companies have no incentive to negotiate. They know that, yes, there will be some patients who get hurt in this and what's going to happen? They're going to blame their physician, and they almost invariably, so it's a win-win for them. Patients will blame the physician, not the insurance company.
That's correct.
And so, the negative publicity and you're right, the overall decreased costs. So
there's another party in this too, which is the hospital.
Right.
Because I worked as a hospital-based physician my entire career. And every hospital I've ever worked at, once they let the patient in the door and accepted the patient's insurance, they had arrangements with the physicians, especially in the emergency situation, to accept the patient's insurance. So how the hospital could have a general surgeon taking emergency room call and not have an understanding like that with the surgeon is mind-blowing to me. I mean, if a community hospital, for example, if they don't have an arrangement with a real super specialist like a pediatric neurosurgeon, okay, then they should send the patient to another hospital. But to not have a general surgeon on your ER panel who's going to take the patient's insurance in an emergency situation, the hospital has some role to play in that.
I would agree. And I would say that, it's a very significant role because ultimately they know that this situation is going to happen. General surgeon, they're going to be called for so many things that this is clearly could not have been either the first time this happened, is just maybe the first time this got presented to the Washington Post. But you're absolutely right. That's on the hospital. That's on the insurance company. And I'm not absolving a physician of if this happened the way it was described. I'm not absolving the physician. I don't think you are either.
No,
but absolutely, there was no attempt. It doesn't seem to present a nuanced thought. It was just a sensationalistic article, and once again, a very easy way to get patients riled up. And who are they attacking? The easiest target in this case, because that was they presented to him, the physician.
Right. And the Washington Post, the Washington Post has clearly had a very anti-physician bias for a long time. So the two economists, Professor Case and Professor Deaton is a Nobel Prize winner. I feel sure that the talk they actually gave at the Economist meeting that they were attending was very balanced, really understood the details. I would not doubt that it talked about the role of the insurance companies and excessive government regulation and everything else that plays a part in the high price of American healthcare. But what does the Washington Post pick up? It picks up the one line, which was an off-the-cuff comment in the hall, apparently, about physicians being part of this giant conspiracy to separate people from their money. And of course, the Washington Post leads with that, and that's all the public sees.
Exactly. It's yes, that because we're in a soundbite headline kind of world, and so more than the reporters, in this case, the editors. really determine what we're going to see, because they're basically framing the conversation. The headline, who sometimes the reporter has no control over, is exactly how then the tone of the article is going to be read. So,
Exactly. So in my blog, what I tried to do is just present the other side.
And we appreciate it. And I'm assuming, given the number of people that have viewed your blog, and then from the Kevin MD site, I got to imagine that a number of them are not physicians, and some of them, maybe awakening to what the issues really are facing physicians now. So I'm glad that
true. It's been really interesting. I've had on my little blog, which isn't monetized, and I just do it. It's a labor of love.
Mm-hmm.
But that one article has had more than 330,000 views.
Wow.
Thursday night, which is, as I say, really kind of amazing to me. But what's been gratifying is there have been comments from the public, from nurse practitioners, from PAs, people who work with physicians all the time, coming to our defense as to how hard we work and what they see, which is really kind of touching.
Yeah.
And patients saying how much they do appreciate their physicians. Now, naturally, there have been some negative comments. Oh, physicians are just greedy. You all just make too much money. Get over it. Stop whining. And I don't really think my tone was whining at all. I don't whine. I let my children whine. But it's been, in some respects, moving, because the plight of some physicians in this country, and even more so in foreign countries, is really sad. I've gotten comments from India about physicians feeling in fear of their lives if they have a bad outcome, that patients' families are actually going to physically attack them. If you read some of the comments on my blog, they really are heartrending.
It's true. I mean, I think what's happening here is that, and we see these comments and articles, if you see the difficulties that healthcare workers in the supposed ideal, healthcare countries, like, the ones with universal healthcare, or at least the described ideal healthcare countries, the NHS in England has a chronic understaffing shortage. There was just an article this week about doctors in Paris, basically, dropping their their white coats as a form of protest due to chronic understaffing issues there. And it's beyond just physicians. I think all people who are actually providing healthcare, whether it's nurses, nurse practitioners, physician assistants, physicians, technologists of all different types, we're kind of being caught in the middle of this unending increase in healthcare costs. Meanwhile, cost cutting to the bone at the staffing level, and so we're being put in a very difficult place. And like I said, it's not just physicians; it's all of us together in the healthcare team.
Yes.
But I agree. I saw some of those comments on your blog, and it just echoes that it's becoming a very difficult, and it always has been, but it seems like it's becoming more difficult. Maybe just due to recency bias. I don't know. But you wrote something, and that was kind of the headline that you would see on the various social medias, as about basically not having physicians in 10 years when you need them. So do you think there's going to be a physician shortage in 10 years?
There's already getting to be a physician shortage. It's not an overall shortage in the way that you might think simplistically about it, but there are shortages, first of all, in primary care, and especially in primary care in more outlying areas. Everybody gravitates to the big cities because it's where we all trained.
Right.
But beyond that, there's been a real change. The American Association of Medical Colleges is really concerned about the upcoming shortage in surgeons.
Yeah.
And I think there are several factors playing into that. One of them is the fact that people are concerned today with work-life balance. Now, that's something that my generation of physicians never heard of, never gave a thought to. It wasn't even a word.
Right.
It didn't exist.
Absolutely.
And frankly, I disagree with the concept a little bit, because to me, the opposite of work is leisure and the opposite of life is death. And so I don't understand putting your work and your life as opposites, but okay. But that being said, people are not going into fields like vascular surgery, general surgery, neurosurgery, cardiac surgery. There are more positions than you would think going unfilled. And the fact that 50% of medical students are now women is unfortunately going to affect that too, because there are very, very few women that are electing those residencies. So
can I ask you something in that? And because that is a very important statement. And it's one that on the surface can be thought of as almost inflammatory, just because, women are they choosing to not go in, or they're not being allowed to go in. And I ask you that as a woman who has gone through a demanding specialty, because I think
they're not choosing to go into it.
Okay.
They really are not. Now, I think you could have another whole conversation about whether they're not being encouraged to go into it or what. But even in my field, anesthesiology, which is arguably more technical than a lot of specialties, we can't seem to break the barrier of more than 30% women in our residency programs, even though we try really hard to recruit good women to come into it. So, I mean, I hope we're making a little progress there, and I hope people like me can help demonstrate that anesthesiology isn't just a dry technical field. But nonetheless, if you want to have a family and you're looking at a 10-year residency, that's got to be daunting.
Absolutely.
And there's just no question that having kids has a different toll on men and women. It just does.
Right.
And so I don't blame women at all for not wanting to go into vascular. I have yet to meet, I think I've met one woman in vascular surgery in all these years. I know only a couple in cardiac surgery. I only have had one woman in all these years that has decided to go into my specialty, which is thoracic anesthesiology, which, is tricky because you're taking somebody who probably has bad lungs to begin with, and then you have to ventilate only. Sorry about these beeps.
Okay.
I had to turn them off.
No problem.
You have to ventilate one lung while the surgeon operates on the other one in a patient whose lungs were poor to begin with. It's very technically challenging. The hours are unpredictable. The cases are long and difficult. And a lot of people, men and women in anesthesiology, they want to go take a job where they work in an ambulatory center, no nights, no call, no weekends. Well, okay. But that's where the physician shortage is going to come from. It's in the demanding hospital, the cases that can't be done in outpatient centers.
Right. And I think that's true. I mean, you're absolutely right, because there are certain fields that have never and probably can't lend themselves to work-life balance the way we try to idealize things. And so, and it's going to be difficult, because you're right. More and more people are concerned. I think, women, but also younger men too. Exactly, are also. And I don't think it's a bad thing. Exactly like you said. I think but it will leave us with these potential unintended issues, and that being shortages of physicians. In fact, one of the interesting articles that came out last year, one of your fellow anesthesiologists, you may have heard of him, Physician on Fire. He's a blogger now who's retired, and he, at the young age of 42 or 43, and he talked about that in an article on Doximity, and it was amazing. There was a lot of mixed reaction, as you can probably guess, because a lot of people were, saying, well, tremendous work that you were able to save, and then you get to do what you want. And then I don't know if it was an equal amount, but at least a sizable portion were also like, well, you spent all this time and effort, and now we're going to be short one, anesthesiologist at the prime of their career. And so, it's a tough thing, because we don't want to individually dictate to physicians to what to do, but at the same time, it does leave an issue. It does leave consequences in our field, and these external factors don't help because they definitely are making things much more difficult.
Right. I mean, people used to go into neurosurgery feeling as though they were going to dedicate their lives to neurosurgery, and in some cases overdo it, or cardiac surgery. And families suffered, their role as parents suffered. A lot of things suffered, but they dedicated their lives to it, and people just are not willing to do that anymore.
Right.
So that is probably healthy in one sense, but in another sense, mastering any kind of field in medicine is a combination of practice and experience. And if you don't really get enough practice or enough experience, first of all, you're never going to be first rate.
Right.
And secondly, then if you get to that peak of both and then you leave, well, you could be not charged, but a case could be made that you have really abandoned both your colleagues and patients. And there's even an additional aspect to it, which is that even if you went to a private medical school, but for sure if you went to a state medical school, taxpayers have paid for a lot of your education. And is there not an ethical obligation to give that back?
Right. And that exact comment was made. And I'll tell you a response to that was, well, I've paid hundreds of $1,000s in taxes a year. And that was the response. But I agree. It's a definite ethical question that, I think it's a valid point. And more than just the funding of it. I mean, yeah, we kind of, we know our training is long. We want our physicians to be skilled and very good at what they do, and you don't necessarily get that immediately out of residency or fellowship.
Not at all.
And you get, as we all know, you get better and better with time, and you probably get, occasionally you get more seasoned in terms of your being more humble, and you learn these things as you get along with experience. So I agree. I think those are all considerations, but let's go to the positive side, because you wrote, and one of the questions that I kind of wanted to ask you was, we've talked a lot about this negative side. How can we actually improve the culture in medicine so that we don't stress our physicians out and drive them towards an early retirement?
Well, boy, it's such a complicated question. Interestingly, I think that within the profession, the culture has steadily improved since I was a medical student. Mm-hmm. I think it's a kinder, gentler environment now. I think there's far less abuse, far less intimidation. I mean, every time I read an article these days about, being bullied or intimidated, I think, honey, you have no idea what it used to be like. And I don't mean honey meaning right. necessarily. I just mean, you really, you want to abuse. I
think it's important that, because we are all victims of our own personal perspective. And it's important that, sometimes if you don't have a mentor who's been doing this for a while, you may not get these stories, or if you don't have family members who have gone through this, it's important. So I absolutely, please, I think we should share that. And that doesn't mean that it's perfect now, but it does mean that we're heading towards the right direction.
We are definitely heading in the right direction. I don't think there's any question about that. I think anybody who goes through a residency is going to have a day where your attending is just not happy with you. But of course, we're not working in a simulation lab. We're working in a real operating room in my job, with real patients. And this is not a simulation. This counts.
Right.
They're not necessarily, I may be able to rescue you, but, at a certain point, there's no do-over. We just have to do it right the first time. And I have to get you to where you can do that, or else I need to take over. And that's just how this works. So, it can be challenging, but I think that from the public's point of view, I would like to see a little less entitlement. I think that let's make the comparison of car insurance. Mm-hmm. You buy car insurance, you still expect to put gas in the car and to put the right gas for the car that you have. You expect to take it for its oil changes. You are going to have to replace the tires. You have to take care of the car, and you don't expect the car insurance to pay for all those things. But we have gotten as a society to the point where patients don't expect a copay. They don't feel as though they need to show up on time. They feel as though everything should be covered, and they get the smallest bill, and they're mad at somebody.
Yeah,
That's an attitude change that I certainly can't make happen. But until it does, I think patients are going to find that those doctors just aren't there. They can't get appointments, that people are not willing to put up with this. People that go into medicine are highly intelligent, very motivated, very hardworking. They have choices. They can pick other careers. And that's what I'm afraid may very well happen. And then from the insurance company's point of view, I think really there needs to be some serious reform in the insurance industry. Some patients require more time. Just because it's just a well patient visit or what looks like maybe not a serious problem, many physicians find it is toward the tail end of the interview or the tail end of the encounter that the patient really gets around to talking about what's really on their mind.
Right.
And if you have to cut them off because you have to see 6 patients an hour, which is really untenable, patients aren't going to get the care they deserve. Everybody's going to be frustrated and angry. So it's the corporatization of medicine that is a huge problem. There are also things that could be done within the insurance industry. Every physician's office, every hospital has a huge amount of staff who do nothing but try to deal with all the different insurance companies. Just some standardization of the billing forms and the billing process would be huge. But so far, there's been no mandate to the insurance companies to do that.
I mean, it does seem like they pretty much get off all the, they get blamed as an abstract thing, but you're absolutely right. There doesn't seem to be a cohesive effort to make them make the system more efficient, because in their perspective and from their side, the less efficient it is, the more they profit. The more difficult it is for that physician to get a pre-authorization for that MRI that the patient needs, the less likely they are to go, to do it.
Exactly. That is what happens all the time. And they're also, with the current out-of-network billing problems, the insurers are, first of all, motivated not to sign contracts. And then, if anything, they're pushing for any national legislation to be tied to Medicare rather than to an index like Fair Health, which would actually provide fair payment to physicians. In my field, Medicare actually pays only on average 27% of what commercial insurers' usual and customary payments are. So having any kind of out-of-network billing law that's pegged to Medicare, you're just not going to have anybody in anesthesiology.
Right.
And if you think that nurse anesthetists are going to leap into the breach, well, I've got a bulletin for you. Medicare pays exactly the same for an anesthesia service, regardless of who delivers it.
And to be fair, they're not. Yeah, I mean, it's all going to be simple economics. Yes, maybe they cost less initially, but if they're not going to get, if they're losing money on a service, regardless, it doesn't really matter. So
it does not matter. So this is really an important issue, and everybody out there that's involved in any kind of advocacy, the New York state law is a very good model. If the national law follows the New York state law, then I think patients and physicians both will be well served. If it goes down another direction, it's potentially disastrous.
Yeah. And this is, last time I did the podcast on this topic, we got some traction on it, but this is happening now. I mean, this is the stuff that they're deciding now. And so you need to speak to your representative and tell them where you stand, because honestly, if it goes other than the New York law and they index it to Medicare, insurance companies, they have no interest in negotiating because they want it to get down to that point. They want it to.
Do. They're not interested. I mean, there have been a number of anesthesiology groups in California who have been flat out told by their insurers, we're not going to sign a new contract with you. Just forget it.
Right.
Which they can do, and that's what that is driving physicians into these corporate practices where they're more protected, but at the same time, they're just more cogs in the machine, and the gratification of being a physician with some some autonomy in your life is just gone.
Yes, yes. And in fact, you're 100% right. And that corporation is, also once they're losing money, it's the same thing. You might be able to subsidize people for, a few years with these low interest rates that we have currently, but that's not going to go on forever. And you're not going to take losses indefinitely. They're corporations. They want to make money. So
look what's just happened with Team Health. Team Health just lost a major out-of-network billing. I'm not sure if it was a lawsuit or exactly how the issue was framed, but their response to it was they're just going to cut all the physicians' pay across the board.
Yeah, it's scary because this is why we see so much interest in physicians pursuing alternative careers, whether it's going to pharma, biotech, or whether it's leaving medicine in general, because they're just so tired. And I feel like, unfortunately, this will accelerate the trend. But let's go back to something positive.
Sure. Well, it's a wonderful career.
There you go. I was going to ask you, do you regret choosing a medical career?
Not for a second. I mean, I have loved it. I really have. And my husband and I could retire, and we just can't even imagine retiring right now. We just don't want to. I love going to work. I love teaching my residents. I love taking care of patients, and I always will. The only thing I hope is that I will see when the day comes, hopefully a long time away, when my mental acuity or my physical acuity starts to decline, and I'll leave while they still want me to stay, as opposed to the opposite. But, you look at an entertainer or somebody in sports. And now, if you want to talk about somebody being overpaid, I think some of those people are overpaid. Right. But they're past their prime when they're 30 or 35. Right. You're not going to be the hot young athlete or the hot young actor forever, no matter who you are. So, whereas we have careers that go on into our 50s, 60s, sometimes even 70s, that are very satisfying, that experience is unmatchable, and it's valued. It's still valued. And the other thing is, we get to go to work in the morning and feel good about it. We don't, my job doesn't involve trying to make somebody buy something they don't want or can't afford. Mm-hmm. It doesn't involve in any way anything that I can't be proud of. And my son is a third-year internal medicine resident now. My husband's a physician also. We didn't either encourage him or discourage him. We just wanted all of our kids to go do what they wanted to do. Mm-hmm. But I'm very proud that one of our children is a physician, and I hope he has the satisfying careers that we've had. Absolutely,
absolutely, and I think that's the key thing. I mean, as many challenges as physicians face today, I mean, it's still really, when you get down to the actual practice of medicine, there's really very few professions where you can impact not just the society as as what we do overall, but on an individual basis, and develop that relationship with that one person, their family. And so, although I'm a radiologist, so it's less often that I get to do that, but I know exactly what the positives of our profession are, and so we have to hold on to that while we face these challenges, and try to gain back some of that autonomy that we've lost over the last few decades.
Right. And that's why I do think it's important for people like you and me who do love the profession to talk about what's wrong with it and not just bail on it. Mm-hmm. That's the key. We have to hang in there and try to help the residents and everybody coming up see the good in it.
Absolutely.
And frankly, be a little bit less selfish, because I do think it's an age that's built on what's in it for me right now. And there really is more to life. Mm-hmm. The less you think about yourself and the more you think about other people, frankly, the happier you are in the long run. And that's a lesson that I think does come with time a little bit more easily than it does when you're in your 20s. And I get that.
Right. Yeah, we've all been there, and some of us, some of my listeners are there now. So yes, it does. Your perspective does change, and I'm sure they've all heard that, but generally for the better. So I think that's a really good point that you just made. Let me ask you one last question.
May I say one more thing about what I'd love to see patients do is just take some responsibility for your own health. Work with us. Eat healthy, exercise, stop smoking, don't go out in the sun. Just all the normal things that you hear all the time, but they really, really make a difference. They make a difference in how good you feel. We can't fix decades of neglect with a pill. We just can't.
Absolutely.
And those health problems, the more people take ownership of their own health, the easier it is for us to take care of you.
I think that's, that advice should go directly to doctors as well, because we're notoriously bad at doing that. So,
right.
We are sacrificing on one side, but at the same time, if we want to keep doing this for a longer period of time or anything, take care of yourselves as well. So we tell our patients to, but we also have to live healthier lifestyles. So. Dr. Sibert, thank you. That was really, really great. And like I said, I know more and more of our colleagues are reading this article as we speak. And you've written, many other articles also that I've seen on the Kevin MD site and your website. Tell my listeners your website so they can find more of your articles.
Well, thank you. It's very kind. My website is called A Penned Point, PENNED. POINT. It's got a picture of a quill on it. And I do hope you enjoy reading it.
I'm sure they will. And like I said, I think your article this past week really hit the nail on the head of how we're feeling. And thank goodness we have people like you who can eloquently say what we're feeling and respond to our critics. So thank you, Dr. Sibert. Thanks for coming on the podcast.
It's my pleasure. It was great to talk to you.
I want to thank Dr. Sibert for coming on this podcast and being so gracious. I'm sure after her article went viral, she's been probably inundated with emails. And as she said, over 300,000 views on her own website, over 110,000 shares on Kevin MD for this article. And I wanted to just thank her for her advocacy for our profession, for her giving a voice and her words in standing up to these external entities and telling them the real importance of what we do, the stresses we face, and the difficulties. And please share this article. And I'm sure, and many of you have already done so, but if you haven't, send it to your other physician colleagues and even to your non-physician friends. Let them get a better idea of what we're facing. We're not the enemy. As has been stated on multiple sources, physician salaries are only 8% of healthcare costs, and administrative costs are significantly higher. Let's work on reducing that instead of making issue with the people who work so hard to provide the care. With that, I want to thank Dr. Sibert again, and thank you for listening. Thanks for joining us on another episode of Dr. Money Matters. If this is the first episode you have heard, I appreciate you taking the time out and listening, and encourage you to listen to our past episodes. I would also appreciate you leaving me a positive review on Apple Podcasts, and also recommend you join our Facebook group where we have ongoing discussions about this and other topics in order to help each other reach our financial goals. Finally, I encourage you to subscribe to our email list and also to subscribe to the podcast itself on the various podcast app that you use in order to be kept aware when the latest episode comes out. More episodes of this podcast are available at www.drmoneymatters.com and on Apple Podcasts, Google Play, Stitcher, Spotify, or wherever you listen to your podcasts. Audio versions are also available on YouTube and Facebook. And you can follow me on Twitter at Dr. Money Matters or on Facebook or Instagram at Dr. Money Matters, all spelled out. Thanks for listening, and if you get a chance, please leave a positive review for this podcast, as it helps move the podcast up the rankings on iTunes and gets it exposed to a wider audience. Thanks for listening once again, and stay tuned for another episode coming soon.